I have the privilege of presenting our speaker tonight. Dr. Maurice Scotty Scott is a board-certified family medicine physician, a member of the American Academy of Family Physicians, a fellow of the American Academy of Hospice and Palliative Medicine, and co-director of the Community Hospice and Palliative Medicine Fellowship. I don't know how he has time in a single day. Dr. Scott practices with the University of Colorado Palliative Care Medicine Service, which is accredited by the Joint Commission. He's a CU School of Medicine Compass Guide, a member of the CU School of Medicine Faculty Senate, is on the Equity, Diversity, Inclusion, and Belonging Committee for Palliative Medicine, and teaches the traditional palliative care fellows advanced communication skills. Dr. Scott is on faculty with the University of Colorado School of Medicine in internal medicine. In his spare time, Dr. Scott likes to exercise, spend time with family and friends, and read nonfiction, spiritual, and biographical books. Fun fact, Scotty and I were residents together, and he was my chief. I'm honored and privileged to welcome you tonight, Scotty, a dear friend and a most admired human being. Colorado's in for a treat.
All right. Good evening, everyone. Can you all hear me? All right. So as Dr. O'Connell said, my name is Maurice Scott. I go by Scotty. Please call me Scotty. And before I get into the objectives, I thought we would start this by taking a beat, making sure that this feels personal to all of you. Oh, hello. Hello. Can you hear me now? Yeah, we'll mic you. Sure. Okay. They did offer me the hookup, and I politely declined the first time, but I will do it this go around. So as they're doing that, I really want to make sure that this session feels personal to you all. Palliative care is very personal, patient-centered type of medicine. We'll get into exactly what it is. But to do so, I believe they gave you all a pen and some paper. And so right now, if you would just take a few moments to consider how you define quality of life. For you as a person, individually, unique to you, things to consider is what a good day might look like. Perhaps it's going for walks, watching Price is Right. Who knows? Again, it's all about you. What would a bad day look like? What kind of things might detract from your quality of life? Perhaps it's physical pain or strained relationships with family and loved ones. Write these down. Hello, can you all hear me?
Dr. Scott?
Yes.
Can you repeat what you asked them to write about?
Yes, please. If you all could write down, looking really for about 8 things, and they can be as detailed or as general as possible, that for you as an individual defines your quality of life. Recognizing that it's going to be different for everyone. We all like to do different things. What fills this up is different. And if you're having a hard time coming up with things, here are some examples that may feel a little bit not as personalized to you, but may resonate with you nonetheless. And these are directly from a card game called Go Wish, which is an advanced care planning conversations starting card game for palliative care that we use oftentimes with patients, families, and learners. Folks feeling pretty good? You're getting up to the 6 to 8 range? All right, then we will keep moving. So if you've ever been to one of my lectures, which I assume you have not, the only time I play PowerPoint karaoke is with the learning objectives. To define palliative care, that's one thing we will be doing today, to recognize disease trajectories from a palliative perspective, and then to explore the benefits of values-based goals of care discussions. So how do I describe palliative care? I describe palliative care as a specialty in medicine that focuses specifically on quality of life and trying to ease and relieve suffering, however that means for that particular patient. We work hand in hand all of the time with other physicians we've heard of, intensive care doctors, kidney doctors, pulmonologists or lung doctors, cancer doctors, as they're trying to treat those illnesses, to extend life or to cure them. Our group wants to make sure that any pain gets well controlled, any nausea, vomiting, constipation, things that can make it really difficult to enjoy even a moment, to enjoy the ability to go to a movie or engage in a conversation. We also try to get to know who people are outside of their illness. In medicine, too frequently, when you interact with the healthcare system, it all focuses on the pathology. It all focuses on the pathophysiology, and it can be very scientific, and it leaves out everything of who we are as people. And so we work with an interdisciplinary team of chaplains, social workers, physical therapists, child life therapists, pharmacists, all with this lens around how are we going to create or optimize quality of life for patients and their families who are going through serious illness. You can see up here from this figure that there are quite a few people on this interdisciplinary team. In theory, not all hospital systems or all hospitals have those, but anyone who feels that palliative care is the lens through which they like to view the world, or at least patient-centered care, this could be a good fit for them. It really is a team. There's not as much of a hierarchy. For those of you who have played team sports, certainly you may need a team captain to help guide, but everyone on the team can be a crucial member. And sometimes that crucial member is not going to be the physician, even if the physician historically is the team lead. This palliative care is different from hospice. Hospice, while there can be overlap when it comes to kind of trying to focus on quality of life, focus on comfort, palliative care occurs much further upstream in a person's illness. Folks who are still wanting to get cancer treatment therapies, still wanting to come back and forth to the hospital if they were to get sick, still wanting to get dialysis, all of those things folks can do and get palliative care on top of it, because all of those other specialists don't specialize in symptom management. All of those other specialists are not trained to view people as palliative care folks are trained to view people. So they really can be complementary in any time in any time or stage of serious illness. So to describe this slide for you, kind of on the top is historically how folks have considered palliative care. Both healthcare providers as well as the patients and families who were who knew what palliative care was within the last kind of 20 or so years. As you can see, going from left to right, at the time of diagnosis on that top bar graph, for the most part, folks are, we're going for life-prolonging or curative treatment. You're still going to see the cancer doctor, you're still going to see the pulmonologist, still see the kidney doctor. And it's not really until the very end where you say, okay, well, now let's start making sure that quality of life is matching these treatments. Now let's make sure that pain is very well controlled. Let's make sure that nausea is well controlled so you can go to the movies. What we in our field are really trying to promote is the bottom graph, where you can see here at the initially diagnosis, folks may come in and they may not have symptoms. It may not have affected their lives. You've gone to see your primary care physician and they say, hey, we got some labs back on you. It looks like you have a worsening kidney disease, or maybe we did a chest x-ray or something and it looks like you have COPD. You may not have symptoms. And so at that point, right, most of the treatments, if not all of the treatments, would be for curative intent, or certainly to slow the disease progression. But as the disease continues to worsen, which most chronic illnesses do continue to worsen, the symptomatic burdens, both physical pain, non-pain symptoms, can get worse, oftentimes do get worse, as well as how the impacts on you as a person, on your family as people. It can impact, your relationship with your God. It can impact relationships with, with your partner, with your children. It can impact your job if you're all of a sudden having to go to all of these appointments. And then how are you going to access resources to literally pay the bills moment to moment, day to day? So we, as you see then, kind of continuing on this progression of chronic illness, as the illness gets worse and worse and worse and worse, and we know that eventually there will be no curative treatments or no way to slow or manage that disease. At the far end, where you see all the dark blue, that's hospice. But everything before that, this dark blue, is palliative care. And so there's quite a bit of opportunity if we can, with your help, as well as with kind of a shift in thinking amongst physicians and amongst the healthcare providers, to help manage symptoms a little bit better, focus on quality of life, redirect the care to focus on things that really matter to you, that don't matter to, or that really matter to you, that may or may not matter to the physicians. We can get very detailed and nerdy around physiology and pathophysiology and forget what it is, how that affects you. All right. So to be able to do this and practice palliative care, those of us in the field and you all who will be engaging at some point over the course of your lives with the healthcare system, it can be very helpful to know generally how diseases progress. You're diagnosed with something. What might your future look like as you're trying to get treatments for these things? So I'm going to start this video. It's about 3.5 minutes, and I will be right back.
Common disease trajectories. Here are some important medical terms. Prognosis is the prediction of possible development of a disease. Trajectory is the expected path of a disease. Patients with palliative care needs commonly have one of the following categories of illnesses: cancer, organ failures such as heart failure or kidney failure, frailty-related illnesses such as dementia or Parkinson's disease. When comparing patients' function over time, each of the categories of illnesses has different trajectories. Different trajectories of illnesses mean that each group of patients requires different approach to medical management, care planning, and psychosocial support. Here we describe 3 trajectories. Number 1, rapid trajectory that usually happens in cancer. It is characterized by a fast physical decline towards the last few months of life. As the patient becomes weaker, it also means that the illness is developing faster. Ideally, advanced care planning, or ACP, and palliative care should start at diagnosis of illness, even when they are physically well, so that conversations about values, priorities, and treatment options can begin early in the trajectory. The focus is on improving patients' quality of life, reducing symptoms, and preparing them emotionally, spiritually, and practically. Number 2, intermittent trajectory that usually happens in organ failure. It is characterized by episodes of sharp physical declines due to acute medical changes. There can be recovery of function after each episode, but it may not return to the original function. Prognosis of the disease is difficult, as any one crisis can result in death. ACP should be in place to understand patients' wishes while they are well, as deterioration is often sudden and fast. Therefore, timely involvement of hospice care is important, and early palliative care can help to improve patients' and families' quality of life and coping. Number 3, gradual trajectory that usually happens in frailty. It is characterized by a very slow functional decline over time. There is no clear sign as to when patient is at the end of life stage. The slow decline also means that caregivers and families are at risk of burnout due to prolonged caregiving. ACP should begin before patient loses his mental status or communicative function. Difficult decisions, such as the need for tube feeding, should be discussed with patients and families. Support for them is important to minimize caregiver stress. In conclusion, by understanding these three common trajectories of diseases, we can better plan for care needs of patients and their families.
Back. There we go. We'll figure it out one way or the other. So that really is kind of a global disease trajectory, you know, and when you go and see your physician, what you're dependent on what your health issues are, you know, you can anticipate, generally speaking, that your trajectory in health may look something very similar to one of those, dependent on what it is. As a result of that, right, then it would be important for the healthcare system to know what you're hoping to do. What do you want to do with the time that you have? How will that time look? Who should help me make these decisions? You know, if I can't make these decisions for myself, who in my support system could be that point person who knows my values to help guide the doctors, help guide the nurses, you know, all the social workers to do right by me, to have the system work to the best of its ability on my behalf, unique to me. So I'm curious, you know, if you look over again the listed values and qualities, or excuse me, look over your listed values and what quality means for you. Now, if I were to ask one of you, or you were to ask me, you know, neither of us, I can't presume I know what gives you quality, nor can you presume to know what gives me quality. And so I need to ask you, I need to put the medicine aside for a minute and get to know who you are as a person. Be curious in questions that I'm asking. What makes you tick? Have you ever heard a medical provider start a conversation with you this way? No. So how we do it here at the university, and generally speaking in palliative care, is, you know, I'd say, hey, well, it's nice to meet you. I've spoken with all of your doctors. I've described palliative care. I've know in your chart what's going on, but none of that has to do with you. While it does, there's so much more to you. And so, you know, if we can put that aside, we'll get back to it. And just who are you? You know, what makes you tick? What is a good day? Kind of similar questions that I wanted you all to not wrestle with, but marinate on, so that you then can, you know, you have these conversations. Well, this is what I like to do. This is how these are the family or the friends that I enjoy hanging out with. I want to be active. Or again, you know, I'm okay. You know, I just like to hang out on the couch and watch Price is Right. You know, and those things, knowing those things are going to be very helpful for you. You know, other questions, and we'll get into that a little bit. Other questions that can be good, you know, are kind of what makes a good day for you? How are you coping with all of this? You know, 6 months ago you were feeling just fine, and now you got a diagnosis of metastatic cancer. Like that's a big life change. And so to address some of the psychosocial stuff, the spiritual, existential issues that might arise, you know, are things that we want to address in palliative care comprehensively for you, really trying to treat the whole patient. I'm not a chaplain. I don't have spiritual care expertise. And I'm really comfortable asking any single one of you about your spirituality as almost like a primary screen to then get to see if there are chaplains, you know, chaplains that can support you, social workers that can support you. Do we need to bring in your priest? You know, do we need to bring in your pastor from your home church who knows you and can help guide some of these conversations? Again, based around your values, which should be different for everyone. And then with this information, knowing your values, knowing what you like to do, knowing what you know, when you're not in the hospital, when you're feeling the best, what you're hoping to get back to, that really does help serve as a framework for the medical teams to create a plan that gets you back to that goal. It also creates a framework for the medical team to be able to have, you know, a possibly very difficult conversation if and when they determine that you're never going to be able to get back to that goal. And knowing then what your goal is, We may have to have hard conversations, and that happens in healthcare often, but then we can always remain on the same page with you, recognizing that your voice has stayed lifted to the top. So the last thing we'll do, and then we'll answer questions, is let's try to bring this all together, okay? And see how you all feel and how this resonates with you. You still have your list of values, yes? Okay, pull out your pen, hold on to your values, and I'm going to read you a story. This is a story it's a true story. It was, I believe, initially in the New Yorker magazine by Dr. Atul Gawande, who's a head and neck surgeon out of Boston, Massachusetts, okay? Sarah Thomas Monopoly was pregnant with her first child when her doctors learned that she was going to die. It started with a cough and pain in her back. Then a chest x-ray showed that her left lung had collapsed and her chest was filled with fluid. A sample of the fluid was drawn off with a long needle and sent for testing. Instead of an infection, as everyone had expected, it was lung cancer, and it had already spread to the lining of the chest. Her pregnancy was 39 weeks along, and the obstetrician who had ordered the test, broke the news to her as she sat with her husband and her parents. The obstetrician did not get into prognosis. She would bring in an oncologist for that. But Sarah was stunned. Her mother, who had lost her best friend to lung cancer, began crying. The doctors wanted to start treatment right away, and that meant inducing labor to get the baby out. For the moment, though, Sarah and her husband, Rich, sat by themselves on a quiet terrace off the labor floor. It was a warm Monday in June 2007. She took Rich's hand, and they tried to absorb what they had heard. Monopoly was 34. She had never smoked or lived with anyone who had. She exercised. She ate well. The diagnosis was bewildering. "This is going to be okay," Rich told her. "We're going to work through this. It's going to be hard, yes, but we'll figure it out. We can find the right treatment." For the moment, though, they had a baby to think about. "So Sarah and I looked at each other," Rich recalled, "and we said, we don't have cancer on Tuesday. It's a cancer-free day. We're having a baby. It's exciting. And we're going to enjoy our baby." On Tuesday at 8:55 p.m., Vivian Monopoly, 7 pounds, 9 ounces, was born. She had wavy brown hair like her mom, and she was perfectly healthy. Cross out one of your values. Three weeks after the delivery, she was admitted to the hospital with shortness of breath from a pulmonary embolism, a blood clot in the artery to the lungs, which is dangerous but not uncommon in cancer patients. Then, in October, a CT scan showed that tumor deposits in her left lung and chest and lymph nodes had grown substantially. The chemotherapy had failed. She worked hard to take the setbacks and side effects in stride. She was upbeat by nature, and she managed to maintain her optimism. Little by little, however, she grew sicker, increasingly exhausted and short of breath. By November, she didn't have the wind to walk the length of the hallway from the parking garage to her doctor's office. Rich had to push her in a wheelchair. This is the moment in Sarah's story that poses a fundamental question for everyone living in the era of modern medicine. What do we want Sarah and her doctors to do now? Or to put it another way, if you were the one with metastatic cancer, or for that, similarly, an advanced emphysema, congestive heart failure, or dementia, what would you want your doctors to do? People have concerns besides simply prolonging their lives. Surveys of patients with terminal illness find that their top priorities include, in addition to avoiding suffering, being with family, having the touch of others, being mentally aware, and not becoming a burden to others. Our system of technological medical care has utterly failed to meet these demands, and the cost of this failure is measured in far more than dollars. Cross out another value. Earlier that summer, a PET scan had revealed that in addition to her lung cancer, she also had thyroid cancer, which had spread to the lymph nodes of her neck, and I was called in to decide whether to operate. This second, unrelated cancer was in fact operable, but thyroid cancers take years to become lethal. Her lung cancer would almost certainly end her life before her thyroid cancer caused any trouble. Given the extent of the surgery that would have been required and the potential complications, the best course was to do nothing. But explaining my reasoning to Sarah meant confronting the mortality of her lung cancer, something that I felt ill prepared to do. My solution was to avoid the subject altogether. I told Sarah that the thyroid cancer was slow growing and treatable. The priority was her lung cancer, I said. Let's not hold up the treatment for that. We could monitor the thyroid cancer and plan for surgery in a few months. Cross out another value. I saw her every 6 weeks and noted her physical decline from one visit to the next. Yet, even in a wheelchair, Sarah would always arrive smiling, makeup on, and bangs bobby-pinned out of her eyes. She'd find small things to laugh about, like the tubes that created strange protuberances under her dress. She was ready to try anything, and I found myself focusing on the news about experimental therapies for her lung cancer. After one of her chemotherapies seemed to shrink the thyroid cancer slightly, I even raised with her the possibility that an experimental therapy could work against both her cancers, which was sheer fantasy. Discussing a fantasy was easier, less emotional, less explosive, less prone to misunderstanding than discussing what was happening before my eyes. Cross out another value. Between the lung cancer and the chemo, Sarah became steadily sicker. She slept most of the time and could do little out of the house. Clinic notes from December describe shortness of breath, dry heaves, coughing up blood, and severe fatigue. In addition to the drainage tubes in her chest, she required needle drainage procedures in her abdomen every week or two to relieve the severe pressure from the liters of fluid that the cancer was producing there. A CAT scan in December showed that the lung cancer was spreading through her spine, liver, and lungs. When we met in January, she could move only slowly and uncomfortably. Her lower body had become swollen. She couldn't speak more than a sentence without pausing for a breath. By the first week of February, she needed oxygen at home to breathe. Enough time had elapsed since her pulmonary embolism, however, that she could start on Pfizer's experimental drug. She just needed one more set of scans for clearance. These revealed that the cancer had spread to her brain, with at least 9 metastatic growths across both hemispheres. The experimental drug was not designed to cross the blood-brain barrier. It wouldn't work. Cross out another value. For Sarah, there would be no miraculous recovery. And when the end approached, neither she nor her family were prepared. I always wanted to respect her request to die peacefully at home, Rich later told me, but I didn't believe we could make it happen. I did not know how. I spoke to Dr. Susan Block, a palliative care specialist at my hospital, who has had thousands of these difficult conversations and is a nationally recognized pioneer in training doctors and others in managing end-of-life issues with patients and their families. You have to understand, Block told me, a family meeting is a procedure, and it requires no less skill than performing an operation. One basic mistake is conceptual. For doctors, the primary purpose of a discussion about terminal illness is to determine what people want, whether they want chemo or not, whether they want to be resuscitated or not, whether they want hospice or not. They focus on laying out the facts and the options, but that's a mistake, Block said. A large part of the task is helping people negotiate the overwhelming anxiety about death, anxiety about suffering, anxiety about loved ones or finances, she explained. There are many worries and real terrors. There is no single way to talk to people with terminal illness through the process, but according to Block, there are some rules. You sit down, you make time, you're not determining whether they want treatment X versus treatment Y. You're trying to learn what's most important to them under the circumstances so that you can provide information and advice on the approach that gives them the best chance of achieving it. This requires as much listening as talking. If you are talking more than half the time, Block says, you're talking too much. Cross out another value. The words you use matter. According to experts, you shouldn't say, I'm sorry things turned out this way, for example. It can sound like pity. You should say, I wish things were different. You don't ask, what do you want when you are dying? You ask, if time becomes short, what is most important to you? How do you want to live? Sarah Monopoly had had enough discussions to let her family and her oncologist know that she did not want hospitals or ICUs at the end, but not enough to have learned how to achieve this. From the moment she arrived in the emergency room that Friday morning in February, the train of events ran against a peaceful ending. There was one person who was disturbed by this, though, and who finally decided to intercede, Chuck Morris, her primary physician. As her illness had progressed through the previous year, he had left the decision-making largely to Sarah, her family, and the cancer team. Still, he had seen her and she had seen her and her husband regularly and listened to their concerns. That desperate morning, Morris was the one person Rich called before getting into the ambulance. He headed to the emergency room and met Sarah and Rich there when they arrived. Morris said pneumonia might be treatable, but he told Rich, I'm worried this is it. I'm really worried about her. And he told him to let the family know that he said so. Cross out another value. After her parents arrived, Morris talked with them too. And when they finished, Sarah and her family agreed on a plan. The medical team would continue the antibiotics, but if things got worse, they would not put her on a breathing machine. They also let him call the palliative care team to visit. The team prescribed a small dose of morphine, which immediately eased her breathing. Her family saw how much suffering diminished, and suddenly they didn't want any more suffering. The next morning, they were the ones to hold back the medical team. They wanted to put a catheter in her, do this other stuff to her, her mother, Dawn, told me. I said, no, you are not going to do anything to her. I didn't care if she wet her bed. They wanted to do lab tests, blood pressure measurements, finger sticks. I was very uninterested in their bookkeeping. I went over to the head nurse and told them to stop. In the previous 3 months, almost nothing we'd done to Sarah, none of our chemotherapy and scans and tests and radiation had likely achieved anything except to make her worse. She may well have lived longer without any of it. At least she was spared at the very end. Her father and her sister thought that she might rally, but when others had stepped out of the room, Rich knelt down weeping beside Sarah and whispered in her ear, "It's okay to let go," he said. "You don't have to fight anymore. I will see you soon." Later that morning, her breathing changed, slowing. At 9:45 a.m., Rich said, "Sarah just kind of startled. She let out a long breath, and then she just stopped." You know, as you all are reflecting to yourselves, and I'll take some questions, and such. Now that you know the intent of this exercise, with the values-based stuff, and you know the end of the story, how might your priorities shift if people got to know what you valued, what we were hoping for, even before treatment was offered? Could the information along with prognosis and disease trajectory make you make different decisions, reprioritize your values, what's most important when you have to choose, when you're forced to choose? How might you decide to continue or stop going to the hospital once you understand that treatments available will not get you closer to your North Star, to what you're hoping for most? Would you be willing to undergo an attempted resuscitation so that out of town family has time to visit, say goodbye, and an attempt to make peace in the relationship? Palliative care is a type of field that helps explore this for patients and families. We do this to make every effort to treat the whole person, keep their voice lifted to the top in a plan of care, and make sure the system does right by them as possible. And with that, I thank you.
Thank you, Dr. Scott. We will take turns fielding questions from this audience and then from the Zoom audience. And so if you have a question, raise your hands high and one of our students will race to you to mic your question.
In what settings do you normally practice this type of medicine? Is it hospitals, nursing homes, in-home?
Good question. So palliative care can be provided in all settings. In the hospital, we absolutely see patients who are very sick. And then if from the hospital, we've seen them in palliative care, then we can either get them connected to a clinic in the community that practices palliative care. There's also palliative care agencies that can come to the house if that's easier to continue these conversations as well as manage symptoms.
I've talked to a lot of people who are really afraid of pain at the end of life. That's the thing that a lot of them have expressed to me they're most afraid of.
Mm-hmm.
I've talked with a lot of doctors who've said there should not need to be intractable, insufferable, untreatable pain. That is not a concern that people ought to have. And so I'm asking you, from your practice, is all pain treatable?
I would say that 99% of physical pain can be treated, for sure. And that outside of palliative care, very few physicians are comfortable with the high dose opioids that we use. And so they don't prescribe them in a manner that we would, but we can be very effective at getting pain under control quickly.
How would you define the differences between hospice and palliative care?
So the primary difference between hospice and palliative care, I would say the philosophy is probably the same. The primary difference is when patients are continuing to receive kind of aggressive life-sustaining therapies, dialysis, coming back and forth to the hospital if they need to be on a breathing machine, those kind of things. Palliative care can still be very appropriate. Hospice is the far end of that, where it's only focusing on comfort.
Okay, from Zoom.
Hello. Hi. Okay. So from the Zoom question we have, can you please explain how the Colorado law around having a choice in choosing to end your life plays into the palliative care scenario?
Sure. Very good question. So I suspect that this person is talking about the law around medical aid and dying. For how a lot of the interface between palliative care and this law, palliative care providers oftentimes will serve as one of the two physicians who will either prescribe the medication or qualify the patient to receive medications to end their own lives. For patients to be eligible, they need to be Colorado citizens. They need to have an anticipated prognosis of less than 6 months and be able to administer the medicines on their own, putting the pill in their mouth by themselves, not with family doing it, not otherwise. And then generally most hospices now that the law is a few years old, most hospices support families and patients through this. Again, they don't administer the medicines, but they help with the timing and coordination of logistics, as well as remain outside of the room or outside of the house as the patient is administering these meds, self-administering the meds, and then helping to address any symptoms or issues that come up thereafter.
So I have questions around the whole access to palliative care, and really for all three different disease trajectories that you discussed. So, how typical is it now that palliative care is brought in? By whom? Is it something that's more typically requested, or how does that work?
That's a good question. It really will, it depends on your region, and you know, to speak specifically to Colorado, I think that unfortunately palliative care can still be a happy accident for patients and families, you know, and so unless you all know about it, or the physicians or medical providers know about it, it can be difficult to access. However, you know, once it is something that is on the radar, it can be very easy to access. You know, the primary care physicians can make referrals to outpatient palliative care or to home-based palliative care communities or organizations, excuse me. And then whatever is your typical copay in insurance, that would be the for a clinic visit, that would be the same copay for a palliative care visit. And then those palliative care agencies, if and when the time is right to transition fully to hospice, say, I'm so sick, I just want to I have all my energy spent at the house and have care come to me and let my body lead the way, then they can easily transition to hospice. Insurance is no, I know insurance is not an obstacle. It's not an obstacle. Palliative for hospice is 100% covered by. It's 100% covered by Medicare and most of the commercial insurances. And then for palliative care, as I alluded to, it'd be about a copay, an outpatient copay to a kidney doc, similar.
Okay, so another question from the chat we have, if a doctor who is EOL-MAID sets up the end with the patient and fails to be able to do what is expected of them, and the coroner is called to the scene, where the DC will be signed suicide, not natural, how can we prevent this? And if a patient dies before they use the EOL meds and no one knows about the situation, how can this be prevented also?
Repeat the question for me. Yeah, I'm reading it. Okay. If a doctor who is end of life prescribe, or who is an end of life physician and prescribes the medical aid in dying medicine, sets this up for the patient and then fails to be able to do what is expected of them, and if the patient fails to do what is expected of them, then generally, I guess I don't know a good answer for this. Because generally those patients are still in hospice. Generally, those patients still are eligible. Generally, those patients still have a 6-month terminal diagnosis. And what I have seen most oft happen where there are issues are when patients self-administer these medicines and then several minutes later they vomit them up. And then it can be a real conundrum. And what do you do? And oftentimes it's waiting out to see, you know, were they able to absorb enough of the medicines for it to take effect? You know, if not, then I think that it wouldn't be going back to the drawing board, but it would kind of be pulling in the ethics committee from the organization, either a hospice organization as well or the hospital organization, and probably re-engaging with both of the physicians who were part of the medical aid in dying process to make the patient eligible in the first place.
My mother had muscular dystrophy onset at age 56, so it's very unusual. But she had the third grid where it was very steady decline. We had to take care of her, and she, you know, to just get her up every day and change her diaper and stuff like that. That even when we had the hospice care workers come, we actually had to do the work for them because a lot of them didn't understand exactly what she needed. And there were times when we would have to take her to the hospital because she would get sick, pneumonia or whatever. And we would have to stay the night at the hospital because, again, she didn't have the ability to even push the call button if she needed something. And so I'm just curious, is that kind of standard when I mean, we had bigger expectations, I think, but then we easily found out that that was not the case.
For sure. So I guess my first comment would be, you know, you've seen one hospice and then you've seen one hospice, and you know, some have more robust ability to provide services than others. I can tell you that there's no hospice that offers 24-hour care at home for patients. And, a lot of folks experience this. Hospice comes in, they might come in 4 or 5 days a week at most for a couple of hours, but that sure does leave 22 hours for family to provide the care. And that's the nursing care. That's, that's cleaning up after folks, that's providing these medicines, that's knowing what to do, hopefully being trained by the hospice in what to do if there is a crisis, so that family really feels fully supported. That's certainly not always the case.
Yeah, because they would offer us, as the caregivers, they'd say, if you want to go on a vacation for a week, that we can put her in this home, but then we would always worry that she's not getting the appropriate care, that 24-hour care that we've been giving her.
Absolutely.
So,
there's because the alternative, how the healthcare system works now is when folks are not able to be cared for at home. There's a lot of families who want to, but they can't for life reasons. They're not able to. How the system works now is that those patients then they either have the money to pay for 24-hour caregiving, and that can be quite expensive. Even if you have funds, that can be up to $10,000 a month to have someone come in. That's a lot of money. And then if that's not possible, then what happens is folks spend down their assets so that they qualify for Medicaid, and then Medicaid will cover a room and board in a nursing facility. In my opinion, it's a terrible, very flawed system, and one that I know on the national level, Center for Medicaid and Medicare are really discussing how to shift the model in a way to provide some of that, provide better 24/7 care.
Okay. So how, as a healthcare provider, do you manage your own mental health and emotions around losing patients?
Ooh, that's a very good question. I lean in hard to my self-care for sure. I wake up relatively early, very early in the morning, and I make sure to get my physical fitness out of the way. I do a Bible study by myself with open-ended questions every day, so I can walk in centered. And I really, while the field can have perhaps have I mean, it can be filled with sadness and filled with tragedy, no doubt about that. It also, there's so many amazing things that happen, and we're able to intervene. I see patients who come in with pain and they haven't had their pain controlled in weeks, and to be able to get it controlled in 20 minutes is a pretty cool feeling, and one that can fill me up.
Okay, I hate to keep going back to the terminating life yourself, but so what happens if you've got a patient who's quite sick? I don't know if they've got a 6-month sentence or not. The family knows and the doctor knows that this person does not want to continue living if, these quality of life things aren't met. But then suddenly this person can't administer the medication. Are they just out of luck?
Mm-hmm.
Even if they've written down and notarized and they're out of luck.
They're out of luck because if someone administers it for them, then they are, I don't know what the legal language is, but it's like suicide by proxy. And that's illegal.
Is that in every state here?
That's in every state. Yes.
Oregon as well.
Mm-hmm.
Okay. Thank you.
Good questions.
My dad requires long-term care, has dementia and Parkinson's, and will deny any medications. I don't know how to make him comfortable when he denies it.
I think it's really trying to lean into what patients are saying. And I think, if your dad is denying it and he looks comfortable to you, then kind of trust what he's saying. Folks who have dementia and they're not able to reply, they still have physical manifestations of pain. They may grimace. They may have a kind of what we call a furrowed brow, or do a lot of moaning or wincing. And so there are some signs that we can look for to say, okay, let's start some medicines You know, but there could be times also, like for this person who's asking the question, excuse me, there can be times, you know, where folks are symptom free for a long period of time and then they develop symptoms, you know.
About a year ago, we got our wills and all that made for my husband and I, and these questions came up. And so we have all our answers, what we wanted in a binder at home, but should our children can't find our binders, is there another method in which this information could be found? Like I'm thinking for UC Health, like my chart, could that be put there?
You can put, yeah, in UC Health, you can get all that stuff scanned into your chart.
That way it gets some kind of guidance for our
Yeah.
family members.
Yep.
Okay. Good to know.
Yep.
Does morphine hasten the end of life, help organs shut down, etc.?
Very good question. The answer is hard no. It does not hasten an end of life. Morphine oftentimes does have it gets a bad rap for doing that. You know, it can get a bad rap because you say, well, folks, you know, they ended up in hospice and they got started out on a morphine drip and then that patient died. And again, every hospice is different, but what I can tell you that the science does not bear out. There is no evidence that morphine hastens end of life. You know, what it does do is it eases the sensation of shortness of breath. If you are short of breath or if you're in pain, you know, and it also eases pain, right? But if you're in short of breath, you're in pain, then your body is so ramped up that you're not going to stop breathing. You know, and then, you know, if we kind of use these medicines judiciously, and we can rapidly use them and quickly up titrate them, but if we use them judiciously, then we will be able to get symptoms under control and before you even fall asleep. Because what happens with these medicines is you fall asleep first, and then once you're asleep, the next step is for the respirations to slow. And then so we know how that happens, but we prevent it much further upstream.